Um, Upper extremity blocks obviously is a big subject, and so we'll do our best, and we'll have a different focus than you usually will see in this kind of lectures. This is my disclosure. It has nothing to do with today's presentation. These are my objectives for today, and always a picture of my mentor, the person that is responsible for me to get into this regional anesthesia business. My mind was set to be to go into critical care. That was I was going to do, and I had already selected Boston as the place to go. And things change. Obviously, I have never regretted. Now, in terms of the techniques you can do in the upper extremity, one form of classify them would be, the blocks above the clavicle, the blocks below the clavicle. Above the clavicle you have interscalene, supraclavicular, in below the clavicle, infraclavicular, and axillary. There are some similarities among the different techniques. Interscalene and supraclavicular and infraclavicular are true plexus blocks, meaning the anesthesia you get is dermatomal in distribution. And unfortunately, the lesions are also dermatomal in distribution. Something happening here. Yeah, sorry about that. So, as I was saying, the anesthesia, but also the lesions are dermatomal in distribution, and they're not in the form of a nerve. So if you were going to produce a lesion in the supraclavicular region, it could be a lesion of C5, or it could be a lesion of C6, and that could go into different nerves, not necessarily into one particular nerve. So it's one way to determine also responsibility when you're doing blocks. And on the other hand, when you're doing an axillary, you are approaching the terminal branches, and it's not a true plexus block because you can isolate the different branches and produce anesthesia of what you need. In terms of the interscalene, as we're going to see earlier in supraclavicular, they both produce anesthesia of the shoulder. And this is something that I am asked quite frequently. Is supraclavicular a block of the shoulder? And evidently it is, because the main innervation of the shoulder comes from the suprascapular nerve and from the axillary nerves. And both are nerves that can be easily blocked when you do a supraclavicular block. The main difference between interscalene and supraclavicular in terms of the shoulder is that the anesthesia of the shoulder that you get with an interscalene is much more focal. As we're going to see it, you deliver it exactly where it's needed. And if it's spread to something else, then it's not, it's not something that your success will depend on. And that's the reason that if you were going to do a continuous technique, put a catheter for analgesia of the shoulder, the preferred technique would be interscalene. Now, how to perform block? If you go into the internet, you will find all sorts of people, usually good-looking people, good car salesmen, presenting, to you how they do their blocks. They have microphonic voices. They're charming people. The kind of people that sells cars, and you get with a lemon home, but you are kind of happy of having bought that car because the person was just so convincing. So you can choose that way of learning how to do blocks, and essentially what they do is that they show you where to put the needle. So you go drive the needle, place it somewhere, and then you deposit an amount of local anesthetic, and you get the results. And then it's legitimate. You can do that if you want. My approach has always been more understanding the concepts, understanding why we do the things we do, the way we do it. So, and this is a little bit what we are going to do today with the upper extremity. So one of the things to take into account is the anatomy, but not the boring anatomy of just mentioning names for the sake of names, but using the anatomy as a tool to help you understand the things we do. So usually what I have to do when I talk about anatomy is neutralize a little bit the cartoon effect that we have in our minds. Because when we think of the brachial plexus, we think of something like this. You know, it's yellow, has labels, and the direction is almost, you know, straight out of the neck. But just imagine my brachial plexus going this way. There will not be a way that C5 could go in that direction, and actually, you know, we'll have to combine with C6 up here in the ear. So there is no room between the emergence of the upper roots of the plexus and the skin. So necessarily, the plexus has to go almost vertically down, and that is helped by a fascia, as we're going to see in a few minutes. So the direction of the plexus is almost vertically down, to the point that if you think of, for instance, the upper, middle, and lower trunk, if you put them in a position that is very anatomical, you're going to see how it would make much more sense to call the upper trunk the lateral trunk, because it will be the closer to the skin. And then the middle trunk will be in the middle, and the lower trunk will be actually the medial trunk. So that will help a little bit to visualize how things are. And since now we use ultrasound, that information comes handy when we're trying to visualize the real anatomy and not the anatomy of cartoons. So talking about the anatomy that is essential in the brachial plexus, obviously we have to recognize that the plexus emerges between the two scalenes, anterior scalene and the middle scalene. So here is the plexus. This is a dissection I did years ago when I was more patient. So is that arrow seen in the, yeah. So you can see C5 there, C6, C7, C8, and a little bit of T1, and the suprascapular nerve over here. This is anterior scalene. This is the phrenic nerve a little bit in front. Middle scalene is this bigger muscle back there. You see the vertebral artery there, the subclavian artery over there. Okay, so there is, we have recognized in this way that the two anterior and middle scalene muscles are very important in our thinking when we're thinking about the brachial plexus. So that space has been called the interscalene groove. I imagine that now the new generations do not recognize that space as much, and thank goodness, because it never existed. It was an invention of our own literature. Actually, it was an invention of Dr. Winning, who got a lot of things right, but obviously he had the right to get things wrong too. So, and this is one of the things he got wrong. So this is from his book, beautiful rendition of the brachial plexus there by the Swedish artist. And here is my dissection. And you can see that in the frontal view, it's really striking how good the representation of the brachial plexus there is in his book. The problem is when you come around to see the space between the two scalenes. And in that case, this is how Winnie conceptualized this: anterior middle scalene, a marriage of equals, two muscles exactly the same, one in front of the other, producing a free border on the lateral side, which was amenable to be palpated. So I don't know if you were subjected to that torture, but you know, when you started doing blocks, somebody will put you there in front of a neck of a patient trying to feel the interscalene groove. Of course you didn't feel anything, but after a while they look at you funny, you decided to say that indeed you were feeling something there. And then a week later, you know, you will be teaching the same thing to other unsuspected physicians. So the ball kept rolling, and the interscaling group palpation was taught from person to person. Now, the true feeling, when the first time you were there and you didn't feel anything, was correct, because that group doesn't exist at all. It's just something, of an invention, because this arrangement doesn't exist. So if you do a dissection, and I'm going to blow it here, you can see that the anterior scaling and the middle scaling diverge from each other dramatically to leave room at the base of that space for the subclavian artery to pass and pulsate. So if the muscles remain at the same distance from origin to insertion, there would be no room for the subclavian artery to pass and obviously not to pulsate. So the divergence, which happens in the sagittal plane, but also happens in the frontal plane, because the middle scaling reaches much more lateral than the anterior scaling does, kind of destroy completely the concept of this groove. There is a space, there is an interscaling space that is triangular in shape, that has a base at the level where the two muscles insert in the first rib, and has an apex toward the upper cervical vertebrae, where the muscles take origin in the tubercles of the transverse processes. So now, knowing this shape, from my perspective, is fundamental when you're trying to do both an interscaling block and a supraclavicular block. Because as you are going to see, it's much easier to see the boundaries of the compartment where these nerves are. They're trying to locate the nerves themselves. So although we are trying to do a plexus block, which entitles to block nerves, what we are interested in is to find the boundaries of a space where we know the nerves are located. And that way, we simplify things significantly. Now, this shape of the triangular shape of the interscaling space explains the complete different views you get just a few centimeters apart. When you put the probe right there above the clavicle, you see the wider portion of the space. You see the subclavian artery, and then you see the arrangements of divisions located posterior or lateral to the artery. And as you go a few centimeters up, then the space narrows to produce a space so narrow that allows the nerves to be only one on top of each other. There's no room to spread them across. And this is only 2 to 3 centimeters away, one space from the other, or one level from the other in the same interscaling space. So keep that in mind when we are talking about blocks. So here I got my butterfly IQ to show in a video how I'm moving from the base of the triangle to the apex, and you see how the image changed dramatically, just moving the probe a few centimeters from the base to the apex and vice versa. So that's just an important concept to have when you're dealing with these blocks. Now, to make the story complete here, so we have a space formed between two muscles, is that gap is closed superficially by a fascia that surrounds the neck and is called prevertebral fascia. It's very sturdy, and you can see in this dissection, I think these were the same cadavers, but nonetheless here, you can see how there is a shiny fiber structure here that you have to remove in order to see this. These are the suprascapular vessels, and this is omohyoid here that has been abused and pulled up. But the idea is that I'm trying to show here, you can see that there is a triangular space, and the space, the gap, is closed by this fascia. So now we have the true formation of a myofascial compartment. So two muscles that insert on the first rib will become the floor of that compartment, and the lid so to speak, will be the prevertebral fascia. So now everything that matters will be located inside, and we're going to go back to that concept in a few minutes. So